Okay, so we have here the topic on the tumor immunology. So this topic will be discussing about the different tumor markers and also the development of the tumors and how our body respond to for the eradication of the cancer or the tumor. Okay, so this topic here try to discuss about here the tumor antigens that's being produced here by the different tumors in our body. And again, it's also try to describe here, discuss also here how our immune system able to be activated and at least prevent or control here the proliferation of the cancer cells. Okay, then we have here the nomenclature with different tumor or cancer. So the naming or the assignment of the name of the different tumors or cancer here is based on number one, histologic cell type. So we speak about the histologic cell type. So let's include here what type of the tissues being involved. So they're being given a name based on the tissues involved or the type of the tissues involved. Okay, the second one we have here some of the tumor antigens or the tumors here being given also name based on the one who tried to discover them. And third one we have here the tissue changes as to the damage or the infiltration that's happened here within the tissues as examined under the microscope. So you can visualize this one during the histopathologic technique. Okay, so we have here the stem cells. So stem cell here refer to our normal cell in our body. So this refer here primarily to the pluripotential stem cell or hematopoietic stem cell. So pluripotential stem cell or the hematopoietic stem cell would have here the capacity to proliferate, differentiate into our normal appearing cells. So it's self-renewal. So we speak about the self-renewal. So it can mature, differentiate to develop here a young cells or it eventually later on become a mature cells. But most likely the self-renewal here, the daughter cell try to resemble the parent cell pa din. And we have also here capability to develop into multi-lineage. That's a property of our pluripotential stem cell where it can develop here to different cell types. And number three, we have potential to proliferate extensively. So that's still under the influence of the different growth factors. But we need to consider here that our normal stem cells in our body, they are proliferating, differentiating to a daughter cells wherein that one still resemble the parent cells. Okay, then we have here the classification of the tumors. So we have here benign and malignant. So characteristics of our benign tumors, so number one, encapsulated. So pag sabi encapsulated, it's only in place. Okay, so it's just only in situ or in place, inside. Okay, the second one, we have here slowly growing. Third one, non-spreading. So hindi siya pupunta sa ibang part ng body natin. Hindi siya nag-metastasize. And number four, minimal mitotic activity. So it would have here controlled na proliferation and differentiation. And number five here, most likely again still resemble our parent cell. So salient features of the benign tumors. So nasa area lang siya. Hindi siya nag-metastasize. And just take here the normal mitotic activity of the normal cells natin. Okay, so we have your example, the benign tumors. So the first one, we have here the benign tumor involving our glands in our body. So we call it one, sir, adenoma. Okay, actually we can identify our tumor here as benign or malignant. Usually pag benign tumors, it end in the suffix oma. Exception for that, we have your hepatoma, melanoma, and lymphoma. So although that one try to end here with the suffix na oma, so they are considered to be our malignant tumors. Okay, so if that one involve here our glands, so we consider that one as we call that one as our adenoma. So that includes here your pancreas, your stomach. So those are your adenoma. Okay, benign tumors here also try to take the form of your polyps. That's our papilloma. And number three, we have here the non-neoplastic lesions. So this is characterized only here by the overgrowth of our tissues. But still, we consider here the tissues pa din natin na nag-overgrow as a normal. Only that dumadami lang sila in terms of the number. Okay, number 4, we have the normal tissue in a foreign location. So like for example, we have your pancreatic tissue na grow sa ating stomach natin. So still consider that one as our benign tumors. So again, benign tumors here, if that one is encapsulated, it's non-spreading. It do not metastasize. Okay, now we have here the malignant tumors. So number 1, characteristics of that, it try to increase in the number of the cells that accumulate. So there's an abnormal increased mitotic activity. Okay, the second one, invade other tissues in our body. Okay, so the third one, disseminate. So dissemination, the spread here may be taking the form by passing through first with our blood vessel, then eventually try to disseminate by going to our lymph nodes, or it can also seed out in the different cavities in our body. So once already migrate to other part of your body, so again, it try to metastasize. So of course here the responsiveness with the treatment, so it depends on kung nag-metastasize na ba siya or hindi. So it will be difficult for us then to manage or to control if that's already metastasized. Okay, number 5, we have your characteristic cellular nuclear feature. And number 6 is try to possess here the receptor with our integrin molecules. So receptor here with the integrin molecules, it would allow it adhere to our extracellular matrix like your glycogen 4 basement membrane, resulting here to the damage of our connective tissues. Number 7 here, so it try to secrete our tumor necrosis factor alpha and tumor necrosis factor beta, responsible for the angiogenesis or the formation of the blood vessels natin. And ang pinaka-feature nito, of course here, pinaka-clear na feature na malignant tumor natin, it try to recur. So pag sabing recur, it try to keep on coming back despite the treatment or the management has been the patient undergone. So even if the patient undergone already the chemotherapy or radiation or even subjecting it to several medications, but still it grow again. So most likely that's one is our malignant tumor. Okay, so we have here the example of our malignant tumors. So the first one, malignant tumor here involving our squamous epithelial tissues, like in the case of the lungs and the pancreas. So malignant tumors also affecting here our transitional epithelial tissues, like in the case of the urinary bladder. Also here malignant tumors affecting our glands, like your colon, your pancreas. So again, if that was our malignant tumor, we call that one sir adenocarcinoma. So kanina, di ba, benign tumor, if it's involved the gland, so we call this one your adenoma. But here, since it was already our malignant tumors, we call that one your adenocarcinoma. Okay, other tumors here, malignant tumors, we have your amine precursor uptake and the carboxylation tumors, like in the case of the, involving here the uh, neural crest. So that's our that's our neuroendocrine tumors, like in the case of the small cell lung carcinoma. We have also here the term sarcoma. So sarcoma here that involve our connective tissues. So like your osteosarcoma, so it involve here your bones, or chondrosarcoma, it will involve here our cartilage. Teratoma, on the other hand, that refers here to the malignant tumors involving here our germ cells, involving here our sex cell producing organ or tissues in our body. So like for example, the testes or the ovary, then we call this one our teratoma. Okay, then we have here the summary of that. So we consider that once our malignant tumor, like it involve here our glands, so tinatawag natin siyang na adenocarcinoma. It involve here our squamous epithelial tissue. We call this one squamous cell carcinoma. Then we have here the term sarcoma. So sarcoma is our connective tissues. Like if that one is our bones, so we call this one osteosarcoma. That one is our cartilage. We call this one chondrosarcoma. If it involve here our hematological origin or hematological or mga lymphoid tissues natin, so We call that one as, like in the case of involving here the lymphoid, so we call this one lymphoma. That includes here mga lymphocytes natin. So it involves here our myeloid cell lines, so we call that one your myeloma. Okay, then we have here the cancer stem cells. So this one is our stem cell which has undergone already genetic mutation. So hindi ito yung kaninang stem cell natin na normally, 'di ba, it try to proliferate, differentiate to produce young or daughter cells which resemble here the parent cells. But in this case, if we talk about here the cancer stem cell, so this is our tumor initiating cell. So once try to proliferate, it can lead to activation of your cancer or tumor na ito. So this one is a tumor initiating cell derived from hematopoietic system. So like for example, your stem cells involving your breast or stem cell involving your brain. So that's your stem cell. However, again, it tries to be subjected to mutation, genetic mutation or alteration. That's why it leads to the production of the tumor or cancer. Okay, the second one have the capacity for the self-renewal. However, here we need to consider that nag-renew or na-reproduce dito is the cancer cell already. Potential to develop into any cell type, again, it's vary on the type of the cancer cell. And number four, capacity to drive continued expansion of population of malignant cells. Okay, so that's our cancer stem cell. So it takes the property of our normal stem cell, only that the problem with this one, what's proliferating on that is already the abnormal cells natin. So di ba, the properties of our normal stem cells, capacity to proliferate, differentiate. However, again, here what's proliferating, differentiating here, because of continued the mutation, will already be our cancer cells. Okay, then we have here the cancer epidemiology. So we have the leading cause of death related to cancer. So up to this day, so pinakamadami pa din ang namamatay leading to cancer of your lungs. Okay, so medyo mabilis itong cancer of the lungs. So once you've been diagnosed with the cancer of the lungs, most likely you have only like 1 month. So yun, mabilis siya. The second one, we have here the colon cancer. And the third one, we have here the breast cancer. Okay, increasing cases of the cancer here. So we have here the lungs, the breast, the prostate, pancreas, multiple myeloma, and we have the Hodgkin lymphoma. Okay, decreasing cases of the cancer here in the case of the cancer of the stomach, cervix, endometrium. Most likely, the reason for the decreasing cases of this cancer here is because of the development of the number one cancer vaccine. So we have already available cancer vaccine for the cervical cancer, diba? That's directed towards the human papilloma virus natin. And of course, decreasing cases here of those cancers also related to awareness among people about the predisposing factors. That's why medyo nag-iingat ng mga tao. Therefore, it try to have a decreased prevalence. Okay, for the cancer in adults here, for the male, so leading cause of cancer here would be the prostate cancer, followed here by the lung cancer, and we have the colon cancer. For the female naman, so you have your breast cancer, so of course, followed here by the lung cancer, and we have also here the colon cancer. Okay, for the children, so the leading cause of cancer here would be the acute lymphocytic leukemia. That's your L1 most likely. The second one, we have your tumors involving here the central and sympathetic nervous system. The third one, we have your malignant lymphoma. Fourth, we have your soft tissue sarcoma, and we have here the renal tumors. Okay, now we have here some of the risk factors for the development of the cancer. So smoking is the main risk factor for the development of the lung cancer. High fat, low fiber diet for the colon cancer. So we have obesity, sedentary lifestyle can have here myriad of as a risk factor for the different cancers. Race, like in the case of the US population, it has been identified that the Black population in the US would be 20% more prone to the development of cancer more than their white population. Okay, specifically here, we have the risk factor for the breast cancer. Number one, we have here the family history. So family history here of the breast cancer, any form cancer, usually involving the first degree relatives. So most likely, if you have already in the family wherein they have already history of the cancer, so most likely the other members would also develop your cancer later on. The second one, we have here the pregnancy more than 30 years old. So late pregnancy na ito. So parang hindi naman, di ba, hindi maganda na naging pregnant at the earlier stage and hindi din maganda na maging pregnant on the latter stage. The third one, we have here the presence of the fibrocystic disease. Number four, the use of the oral contraceptives, including here the hormonal replacement therapy and including also the estrogen therapy. Although, like in the case of the estrogen would have normally protective function with our heart. Diba? So, estrogen helps to prevent the cardiovascular diseases. However, in the case of mga postmenopausal, di ba, bumababa ang level ng kanilang estrogen. And they are becoming prone to the cardiovascular disease. So, for that, may side effect or may good effect ang ating estrogen. Okay, so the good effect of the estrogen, it can protect us, our heart, with the cardiovascular diseases. However, for those patients that are going the estrogen therapy, for example here, it can induce the tumor enlargement. So pag may mga maliliit na bukol tapos nag-undergo ng estrogen therapy, mas lalo siyang lumalaki. And number five here, why the patient developed here the breast cancer. We have here the prior breast or chest wall radiation. So exposure to radiation, X-ray, so ganun. So it's not recommended that you need to undergo X-ray every now and then because you are exposed to radiation. Okay, then we have here the different risk factors divided here to our environmental pollutants. And we have also here the different chemical agents. And we have also here some infectious agents. Okay, so with the relative association with different cancers. Like in the case, for example, before we go with this one, so like in the case, for example, exposure to the UV light or direct exposure to the sunlight can induce the production of the thymidine dimer. So pag nabing thymidine dimer, so usually, di ba, so ang base pairing natin, so your A base pair with a T or the adenine base pair with a thymidine or thymine. But in the case of your direct UV light exposure or radiation, it can lead to the production of your thymidine dimer. So pag nabing thymidine dimer, so instead of the A adenine base pair with a T, so dalawang thymine ang nagbe-base pair. And the production of your thymidine dimer can lead to your skin cancer. So that's another risk factor, environmental factor natin. Okay, so for the environmental factor here, so we have your industrial pollutants, mga aerosol natin. So like asbestos or the silica can induce the development of the mesothelioma. Then we have here lead, mercury, zinc, copper can lead to the lung cancer. Vinyl chloride, on the other hand, can put you at risk for the development of the liver cancer. Benzene, we have your leukemia. Aniline dyes can lead to leukemia or lymphoma. Sorry, aniline dyes can lead here to skin and the bladder cancer. Okay, for the drugs, so we have corticosteroids or the steroid hormone here can lead to our liver cancer. Stilbestrol can lead here to our vaginal carcinoma. Estrogen can lead to endometrial carcinoma, hydantoin with the lymphoma. Chloramphenicol, alkylating agents can lead to leukemia and the lymphoma. Okay, for our infectious agent here, so first we have your Epstein-Barr virus associated with our Burkitt lymphoma. Human papilloma virus and the herpes viridi are eventually trying to predispose you to develop here the cervical cancer. Human immunodeficiency virus 3 or the human T lymphotrophic virus 3 can lead to Kaposi sarcoma. Human T cell lymphotrophic virus 1, which is our oncovirus, can lead here to non-Hodgkin lymphoma. Hepatitis B, since it tries to induce a chronic hepatitis, so it can result here can lead to our hepatoma or liver cancer or liver cirrhosis. Okay, now we have here the different other medical conditions that can also predispose you to develop here the different cancers. Anyway, the Down syndrome will put the patient at risk for the development of the leukemia. Okay, so other than that, we have here the Paget's disease. The Paget's disease is our bone disease. Okay, so that's result here to osteogenic sarcoma. Cryptorchidism, even the Klinefelter disease can result here to testicular cancer. The neurofibromatosis, so sa our brain, so this result here the brain tumor. Esophageal webbing with your cancer of the esophagus. Achlorhydria, there's a decreased gastric hydrochloric acid that can result here to your gastric cancer. Cirrhosis with the liver, cholelithiasis, which is our gallstones, so can result here to gallbladder cancer. Chronic inflammatory bowel syndrome here can result to our colon cancer. Migratory thrombophlebitis can result here to adenocarcinoma. Myasthenia gravis can result to your thymoma, or thymoma here is our thymus is not producing T lymphocyte. And nephrotic syndrome here can result to your glomerular or kidney cancer. Okay, the next one, we have here the stages of the carcinogenesis. Is the progression of the cancer here. So we need to consider here that it starts with a precancerous condition, but if left untreated, will allowing here the cancer cell to undergo several mutation and eventually can lead later on to an invasive na carcinoma. So that's how we try to progress. You start with the non-cancerous condition or precancerous condition because of exposure to your mutation. Then it would have here the continued multiplication or the continued mutation of the cancer and resulting to proliferation. And eventually later on, it can lead here to the invasive carcinoma. Okay, start here with the initiation. Initiation here is our irreversible mutation involving here the proto-oncogene. So the proto-oncogene here, so this is our precancerous gene. So once exposed here to the carcinogen, it eventually result here to irreversible mutation. So pag na-mutate, so it try to allow proliferation of the cancer cell. Second one, we have here the promotion. So that's involve our growth enhancement, where you have as mutation is being passed to other cells in our body in order for that to produce more cancer cells. And the last one, we have here the progression. That's referred here to the development of the cancer to becoming more homogeneous. Becoming more heterogeneous. Okay, pag sinabi natin heterogeneous, so mas lalo siyang hindi nakikilala ng immune system natin. And if our cancer here become heterogeneous, that's one would no longer responsive to your treatment. Hindi na sa respond to the chemotherapy, hindi na sa respond also to irradiation. And of course here, it would lead to the death of the patient already. Okay, we have here the progression of the cancer. So again, this start with the precancerous. Then you try to progress and later on develop here to become your invasive na carcinoma natin. Okay, so again, the progression here is being characterized by the over-exaggeration of the mutation. And also, there's also the suppression here of the tumor suppressor gene. So, si tumor suppressor gene, like in the case of the P53 na protein or the RB na oncogene, so those are our tumor suppressor na gene. So tumor suppressor gene, it try to inhibit the proliferation of our cancer cells. However, here, what you have for that, so it try to delete ito mga tumor suppressor gene natin and therefore wala nagko-control na to stop proliferating the cancer cells. And because of that, so what's going to happen here is that your cancer, so from the manageable na cancer type or stage, magde-develop siya to become your invasive na carcinoma natin. Okay, like in the case of the cervical carcinoma, it starts only with a squamous cell metaplasia. Then later on, magiging squamous cell dysplasia. Then we have here the carcinoma in situ or in site and develop here to become your invasive carcinoma. Endometrial carcinoma start with the endometrial hyperplasia. Then pag pinabayaan, it can convert here to become your atypical hyperplasia. Then carcinoma in situ, Then lastly, it becomes here the invasive carcinoma, which is already end stage. Okay, then we have here the cancer predisposing genes. So this is the gene here that, okay, once activated, it can produce here our cancer. So this cancer predisposing gene here affects the rate of the conversion of our cancer here from the precancerous to become carcinogenic. The second one, it right affects the host ability to repair damaged DNA. Normally, if we have mutation in our body, so like mga point mutation lang where you have only one base pairing na mutation, that still can be repaired by our body. Okay, however, here in the presence of cancer predisposing genes, so this try to inhibit the normal ability of our body to repair the damaged DNA. So therefore, hinahayaan niya na lang na hindi siya ma-repair, and that can result here to the development of our cancer. And this cancer predisposing gene also try to alter the immune ability of the patient's here, immune system of the patient to recognize and to eradicate the antigen or the tumor. So generally, if you have the cancer, it should be immunogenic enough that should be recognized by the host immune system. So therefore, para it would allow here the eradication of the cancer. However, in the presence of the cancer predisposing gene, so it will inhibit here the ability of our immune system to recognize the tumor antigen. So kung hindi siya ma-recognize na tumor antigen, so hayaan lang siya sa katawan natin. And what's going to happen for that is try to keeps on undergoing mutation, and that can result here later on to overwhelming production of your tumor antigens or cancer cells na hindi na rin kakayanin ng immune system na para eradicate it to control or to remove that one. And number 4 here, the cancer predisposing gene affects apparatus that regulate the normal cell growth and proliferation of the tissues. So again, this is or this inhibit the normal functioning of our immune system, this ability to recognize and to eradicate the tumor or cancer in our body. Okay, so we have the term here proto-oncogene. So the proto-oncogene here normally regulates the cell growth and differentiation with the aid here of the different growth factors and transcription factors. However, it is a proto-oncogene, so once undergo mutation, it can result here to become your cancer. Okay, the oncogene, so ito na si cancer natin, si cancer gene. It's because once this one, the carcinogen already activates this cancer gene natin. Okay, so we have here the family of the oncogenes. So the example for that, we have here the growth factor, which is our SIS, the cis oncogene. Epidermal growth factor receptor. We have also here the membrane-associated protein kinase, which is our SRC oncogene. We also here the membrane-related guanine triphosphate protein, which is our RAS oncogene. The RAS oncogene here also can be classified as our cytoplasmic protein kinase. And we have also here a transcription regulator found in the nucleus in the case of your CMYC oncogene. So ito ay mga cancer-inducing na mga gene natin. Okay, so we have here the different oncogene as their association with the different cancer. So the AB1, the AB1 associated with the CML or chronic myelogenous leukemia. MYC associated here with the Burkitt lymphoma. So NMYC associated here with the neuroblastoma. Epidermal growth factor, and we have also here the human epidermal growth factor 2 is for the breast or the mammary carcinoma. The RAS type na oncogene natin associated here with the variety of the different tumor or cancer. Okay, then we have here the body's defense against the cancer. So again, hindi nila hinayaan ng katawan natin that the cancer here going to proliferate as that. So we still have here the defense normally in our body. Okay, so in order for our body to fight or to eradicate here at least the proliferation of the cancer here, so number 1, the tumor should express here as a foreign antigen to be recognized as a foreign substance in our body, allowing that one to be eradicated. Okay, then normal response fail to prevent the growth of the tumor. So that's the reason why na bakit hindi siya napapatay. Where in fact, di ba, bakit meron naman tayong normal defense? Eh bakit hindi siya napapatay? It's because again, hindi nare-recognize ng immune system natin ang ating or ang cancer. Okay, so pag hindi na-recognize, so hindi niya makilala sa foreign antigen, so wala siyang gagawin. But then the cancer keeps on mutating. So time will come here, but dumadami ang cancer cells sa katawan natin. So hindi na siya kayang patayin. The third one, immune system can be simulated to kill tumor cells and get rid of the host tumor. Again, only if the tumor here is been recognized as a foreign antigen. Okay, so we have here the effector cells in our body that helps in the elimination or eradication of the tumors. So number one, we have here your cytotoxic T lymphocyte. Okay, cytotoxic T lymphocyte normally can kill our viral infected cell or the tumor infected cell. Provided here, kailangan nyo si MHC class 1. So MHC restricted ang recognition ng ating and activation ng ating cytotoxic T lymphocyte. So mean to say dapat si tumor infected cells is being presented to the cytotoxic T lymphocyte alongside with your MSC class 1. The second one, we have here your natural killer. So natural killer can also kill our virally or tumor-infected cell. But in the case of the natural killer, so it can kill your tumor-infected cell, provided that one has been coated with our IgG or immunoglobulin. So para mag-activate ang kanyang antibody-dependent cell-mediated cytotoxicity. The third one, so we have also here our macrophage where it try to produce our tumor necrosis factor. So try to induce here the lysis of the tumor. And of course, you have also your antibodies. So if you have your tumor antigen, our body's producing antibodies to react on that and to kill that one. Okay, despite those mga effector cells natin, so why is it that the patient here progress pa din into your invasive na carcinoma? So number one, the reason for that, the cancer here is not expressing tumor antigen na highly immunogenic. So therefore, pag hindi siya maging immunogenic or less immunogenic ang ating tumor antigen, so it will not be inducing our immune response. Since hindi naman siya immunogenic, so hindi siya kikilala as a foreign antigen by our immune system. And therefore, walang gagawin ng ating immune system. Okay, the second one, bakit hindi siya ma-recognize ng ating immune system is because the tumor here is not producing our receptors. So like hindi siya nag-express ng MHC class 1 and class 2, and therefore walang interaction sa ating mga effector cells natin. And number 3, so bakit hindi nag-react ang immune system natin is because the patient is immunocompromised. If our patient is immunodeficient, so all the immune system cells and molecules ng patient natin are not functioning. Okay, then we have your immunoediting. So we have here the 3 stages for that elimination phase. Okay, so here the stage, the tumors are highly immunogenic already. So it starts with non-immunogenic, but then again, it keeps on multiplying, keeps on proliferating. Time will come here, sobrang dami na siya na hindi na kaya na ng immune system natin. Equilibrium range or stage here is mutation occurs over a period of time. So yun, dumadami. And the escape phase, the cancer are mutated beyond the control of the immune system. So ayan, sobrang overwhelming na nila. So hindi na rin sila kaya eliminate. And of course, you die as a consequence of that. Okay, then we have here the cancer staging. So we can have here the stage of the cancer by doing here our histopathological procedure. So very important here that we need to provide a stage of the cancer for the diagnosis of the patient, in diagnosis of the patient, because the management, the treatment of the patient depends on the stage of the cancer. There are some cancer stage wherein the patients no longer be advised to undergo, like for example, surgical operation. So like in the case, for example, of the cervical cancer. Usually, ang cervical cancer natin, kung hindi talaga conscious ang patient with his or her body, so most likely, nadidetect ng cervical cancer pag malaki ng bukol. And most likely, pag malaki ng bukol, it's already equivalent to that's already in the end stage or like stage 3 or stage 4 of cancer, cervical cancer already. So with that, my option na you can perform here the surgical operation where you try to remove the mass or the tumor, or another option for that is you undergo already directly with the chemotherapy. So sometimes better na wag na natin galawin or like subject agad sa chemotherapy na lang instead of having the surgical operation. So again, so kailan ka ba mag-undergo ng surgical operation? So again, it depends on the stage of the cancer. That's why it's very important here that we need to have the cancer stage with the diagnosis of the patient's report natin. Okay, so we have here the basic stage. So the stage 1 is our cancer in situ or localized, mean to say nasa site lang siya where it tried to produce, kung saan siya na area or tissues or part ng katawan natin. Andun lang siya muna, this is stage 1. Stage 2, on the other hand, already try to disseminate by passing through our blood vessel natin. Stage 3, so it involved already here the lymph nodes. And stage 4, it tried to migrate. It tried to be formed already on the other part of our body. So it's already tried to metastasize. Okay, then we have here the severity of the cancer depends on the tumor size. Of course, here the bigger the tumor, so the more advanced the stage of the disease. We have also here the histology involved, so that's already the alteration of the tissues under the microscope. We have also here the involvement of the lymph nodes, or of course, we have also here metastasize. So pag may involvement ng lymph nodes or nag-metastasize na, so we consider this one more advanced and more severe than ating cancer. Okay, so some of the reporting here with the cancer or tumor natin. So we have here poorly differentiated versus our well-differentiated na tumor. So when speak about the poorly differentiated na tumor here, so it would have already here or it try to resemble the parent cell natin in terms of the morphology. So ang well-differentiated naman, so it would take the form already of the mature na tissues natin. In terms of the prognosis, so pag poorly differentiated, this one is more aggressive and less responsive to the treatment. So poor prognosis, ito si poorly differentiated natin. Mean to say, most likely ang recovery rate niyan ay mababa compared to our well-differentiated. Okay, the other classification here, we have the T and M. So T stand here for the tumor size, N kung may involvement man na ng ating lymph nodes. And we have here the M kung nag-undergo na siya ng metastasis. Okay, the next one, we have here the tumor markers. So tumor markers are the protein produced, serving here as the tumor antigen produced by the tumors. So we are using here the tumor markers to differentiate tumor from the normal tissues natin. Of course, here the tumor markers would be positive for the patients or having that tumor or cancer. And normally dapat should be absent or normal sa walang sakit. And the tumor markers also used here to screen for the cancer. The third one, tumor markers used to monitor the recurrence of the cancer. So we can use here the result of the tumor markers to check here if the patient is responsive to the treatment. So if our patient undergo here the treatment, so dapat bumababa ang level ng ating tumor markers. Comparing with the baseline bago nag-undergo ng treatment, then after the treatment, so dapat bumaba na siya. But in the case na before treatment, suppose after treatment, tumataas pa din ang level ng tumor markers or concentration of that. So most likely, the patient is not responsive to the treatment. Okay, number 4 here, ideal tumor markers natin should reveal the presence of the cancer on the stage where it is still susceptible here to the treatment. So pag sinabing still susceptible here to the treatment, so dapat I should reveal that the patient would have the cancer on the stage or at the time duration wherein na pwede pa siyang magamot ang patient natin. So parang what's the use na na-reveal na may cancer ang patient natin and then ang end stage na naman pala siya. So, di ba? Therefore, again, these tumor markers should be positive on the time period wherein the patient should still be susceptible here to the treatment. Okay, number 5, another characteristic here of the tumor markers, the good na tumor markers, it should be present in our biological specimen that will enable us also to measure it using the different laboratory procedures. So dapat may available na mga test methods sa laboratory, and at the same time that tumor markers should be present in all biological specimen as our specimen. So dapat pwede siya sa blood, pwede sa CSF or any other body fluids natin na pwede natin gamitin to check and to diagnose and to measure the concentration. Okay, ideal tumor markers, the results should only occur in the patient with malignancy. So dapat pag mataas ang result ni tumor marker, so dapat it would be in a patient na may cancer. So pag mababa, so mean to say dapat healthy ang patient natin. So dapat ganun ang ating ideal na tumor markers natin. And the second one correlates with the stage and response to the treatment. So again, correlates with the stage and response to the treatment. So the higher the concentration of that, so dapat is the more advanced ang cancer natin. And if the patient has already responsive to the treatment, bumababa dapat ang level ni tumor markers natin. The third one, easily reproducible here. So if you're going to repeat the test procedure, it would able to give you an accurate na test result. Okay, in different time points. But currently, walang perfect na tumor markers. It's because mga tumor markers natin try to overlap with the test result. I mean to say, other tumor markers na kahit normal or healthy ang patient natin, so mataas ang level ng tumor markers na yan, or the tumor markers not only specific for a particular tissues in our body, so pwede rin siya makikita sa ibang organ in our body. And therefore, we can use this tumor marker measurement as one of the tests only to diagnose patient with the cancer. So hindi siya, we should not rely on this one. Because again, there's no perfect na characteristics na tumor markers natin. Okay, then we have here the categories of the tumor markers. So we have here the tumor-specific antigen. So this is our chemically induced. We have also here the TAA or the tumor-associated antigen, which is our virally induced. Carcino-fetal antigen is our embryonic. And the fourth one, we have here the spontaneous tumor antigen. So itong tumor antigen wherein unknown ang kanyang mechanism. Okay, TSA or the tumor-specific antigen, this is our chemically induced. So as what we have discussed in the previous mga slides natin, so you have that a table on the different risk factors for the development of the cancer. So may mga chemical agents that can induce the tumor. Like for example, your vinyl chloride, di ba, it can induce your liver cancer. So yun ang tinatawag natin TSA if that one is our chemically induced. Okay, TSA is our chemically induced. So this one is being induced here by the different chemical agents. So this is the type of your cancer or tumor antigen here that is unique to each of the cancer. Okay, so this one, there's no cross-reactivity between the different tumors. I mean to say like vinyl chloride, so pag vinyl chloride, we're talking about it can induce your liver carcinoma, so it will not induce any other cancer na. So that's why no cross-reactivity between the different tumors. Okay, TAA is our tumor-associated antigen. So this is our virally induced. This one is being induced here by the viral agents. So that includes, for example, your Epstein-Barr, they might try to induce our Burkitt lymphoma. So this is the type of the tumor antigen that's being expressed by the damaged tissue because of the viral infection. I mean to say, ito yung antigen na to or protein substance na ito, hindi makikita dun sa surface ni virus mismo. But rather, ito yung antigen protein here na pinoproduce ng tissues natin because of the effect or the damage brought about by the viral infection. Okay, so this one is very specific to each of the virus natin. So regardless kung anong affected na area sa katawan natin, so if that one is induced by particular na virus, it try to produce as a specific na cancer. So like for example, like Epstein-Barr, so Burkitt lymphoma lang kanyang ini-induce o pinoproduce o kinakos na tumor natin. Regardless kung anong part ng katawan ang affected niya. Comparing here with your chemically induced and the virally induced, so more immunogenic ito si virally induced natin compared with the chemically induced. Okay, carcinofetal antigen here refers to your embryonic antigens. So these are the antigens being produced here during the embryonic stage of our life, or I mean to say the earlier stage of our life. So mga fetus, during the pag fetus pa tayo, we are producing this antigen. So normally dapat ang level nito, once we try to grow older, bumababa na kanyang level. Okay, spontaneous tumor antigen on the other hand, so ito yung ang kanyang mechanism. Okay, we have here the table here for the different classification of the tumor markers and their association with the different cancer. So enzymes, so we have here the PSA, prostate-specific antigen for the diagnosis of the prostate cancer. Okay, for the oncofetal protein, so ito yung mga embryonic natin. That includes here your alpha fetoprotein, so that's for the liver cancer. We have also here our carcinoembryonic antigen for the colon cancer. Okay, for the hormones, so we have your beta-human chorionic gonadotropin for the pregnancy normally, but in the case of the cancer, that was associated with your trophoblastic cancer or medullary cancer. Trophoblastic cancer, like in the case of your hydatidform mole or the H mole. Calcitonin, so it try to regulate hormone, try to regulate our thyroid, so this was associated with thyroid cancer. Adrenocorticotrophic hormone associated with our small cell lung carcinoma. Okay, mucin, so mga mucin natin mga CA or cancer antigen. That includes here C125, C19-9 associated here with the ovarian cancer. CA27-29, CA15-3 associated with the breast cancer. Okay, immunoglobulin, we have here your Benson protein associated with multiple myeloma. Actually, the Benson protein is the first na tumor marker discovered. Genetic alteration, so we have your HER2 and NEO, so human, that's your HER2 NEO associated here with the breast cancer. Other proteins, we have your HE4. HE4 stands for the human epididymis protein 4 associated with the ovarian cancer. TG is our thyroglobulin associated with the thyroid cancer. For the bladder cancer, some tumor markers that includes the nuclear matrix protein 22. Also here, the bladder specific bladder tumor associated antigen, and we have also here the complement factor H related protein. That's all for the bladder cancer. Okay, we have here the laboratory tests for detection here or for the diagnosis of the cancer. So ito yung mga screening test natin for the diagnosis of the cancer. So we have here the colon cancer. So pinaka-screening test natin for the colon cancer is by doing here the occult blood test. So colon cancer would have the bleeding in the stool, and other way you can detect for that, especially for those na mga hindi nakikita na blood, shedding the blood na mga occult or hidden, so you can have your occult blood test. Okay, for the cervical cancer, you can perform here the pap smear. For the breast cancer, you can perform the self-exam, or you can have here the mammogram. Okay, for the prostate cancer, then you can have your digital rectal exam. Okay, laboratory tests here for test on tumor markers. So first, you can perform here your gross and microscopic examination of the tissues through our histopath. So you can have your autopsy or biopsy. Another one, you can also perform here the serological test for the tumor markers. And the third one, you can have here your molecular study, your DNA, RNA molecular diagnostic test, especially for the genetic alteration. Okay, for the molecular diagnostic procedures, so you can perform here the cytogenetic studies like your karyotyping to check for the abnormality in the chromosome. Also here, the nucleic acid amplification technique. Okay, example for that PCR for the detection of the mutation in the genes. And we have also the FISH or the fluorescent in situ hybridization, where you are using the fluorescent chrome or the fluorochrome or the fluorescent dye as your tag to determine the specific na mutation in the gene. Okay, so we have here the frequently ordered mga tumor markers natin. First, we have the alpha-fetoprotein. Alpha-fetoprotein is being produced by the liver on the 12 to 15 weeks age of gestation. And after that, dapat bumababa ang level ni alpha-fetoprotein natin. So beyond 15 weeks, kapag ang level ng alpha-fetoprotein ng patient is mataas, it would signify your neural tube defects like spina bifida, you can have your anencephaly. Okay, the alpha-fetoprotein is also used to diagnose here our non-seminomatous tumor like the yolk sac tumor natin. Okay, so we have the two here, alpha-fetoprotein and the human chorionic gonadotropin. So in the case of the yolk sac tumor, so pinaka-diagnostic na tumor marker natin will be your alpha-fetoprotein. But in the case of your seminoma, so that's involved here, the malignant proliferation in the germ cells, so human chorionic gonadotropin ang ginagamit natin na test, not the alpha-fetoprotein. Okay, CA125 is our marker here primarily for the ovarian cancer. Okay, involving also here the fallopian tube, endometrium, and we have also the endocervix. Okay, carcinoid embryonic antigen here for the colon cancer. But it can also be used as for the pancreatic cancer. Okay, human chorionic gonadotropin, this is our hormone here that is being produced by the placenta normally during the pregnancy. So if our patient is non-pregnant and then you have your high level of the human chorionic gonadotropin, so it would be related to cancer like your high DATD4 mole. You can also have your gestational trophoblastic neoplasm. You can also have your choriocarcinoma. In the case of the male patient where you have your high level of the beta human chorionic gonadotropin, so it will signify here testicular cancer. Okay, prostate-specific antigen. So this one is being produced by the prostate. This is the type of the protein here that is being produced by the prostate. Usually, if there's an inflammation or damage sa prostate ng patient natin. Okay, so if there's an infection, usually ang PSA tumataas if our patient with the prostate infection, prostate inflammation, we have also the benign hypertrophy in the prostate, and even in the recent ejaculation can also increase the PSA. Okay, so when can we diagnose a patient here with the prostate cancer with the use of the PSA? So again, it doesn't mean here that if mataas ang PSA, so automatic na siya na prostate cancer. It's because anything here that resulting to the enlargement of the prostate, not only related to the prostate cancer, can result here to the increased PSA na level natin. So with that, to use here the PSA for diagnosis of the prostate cancer, so dapat we need to take here the ratio of the free form na PSA saka ang total na PSA. If ang ratio ng free PSA with the total PSA is decreased, so that's is for the diagnosis of your prostate cancer. But then again, pag mataas ang PSA alone, so it might be related to other medical conditions na nag-inflame or nag-increase ang ating size ng ating prostate ng patient natin. So hindi siya automatic agad na prostate cancer. Okay, for the treatment here, so we can divide the treatment with the cancer as passive immunotherapy. So, pag sinabi natin passive, so you are giving the antibodies already. There's a passive antibody transfer or the passive transfer here of the mga cytokines. Okay, then we have also here the active immunotherapy. So again, pag active, di ba? So it try to induce our body here to produce antibody against that. So you can give here your cancer vaccine, but also have here your adjuvants. Like for example here, the BCG. So ginagamit pa rin siya for the treatment of the superficial bladder cancer. And you can also give here mga cytokines like your tumor necrosis factor alpha, gamma interferon, interleukin-1, interleukin-12. And of course, here active treatment is made here by the cancer vaccine. We try to induce your antibody production. Okay, so thank you.